Hi folks, this is John Adamson, the Rehab and Documentation Guru, and today I'm responding to a question I got via LinkedIn from a guy by the name of Charles. Charles is doing home care, and it appears from reading up on his message that he does some Part B in the home. And his question is about maintenance therapy. What is a frequency, intensity, and duration prescription that Medicare would recognize or agree to? And he alluded to this, what I'm going to say, which is, it depends. When you look back at the Glenda Jimmo decision, the decision was not predicated, number one, on whether a patient is making progress. So in other words, Medicare can't make a determination on payment based on whether the patient's progressing or not. They can only make it on the determination of whether care is medically necessary. So now you have this very broad-based spectrum of determining frequency, intensity, and then finally duration of care. So let's talk about frequency. How often are you seeing this patient? Well, again, it depends. Now, if the goal, according to the Glenda Jimmo decision, according to maintenance therapy provisions, is to maintain the patient, then we need to have a frequency that allows the patient to actually maintain. If we're seeing that they're declining still, which is part of the decision for the Glenda Jimmo case, but if they're still declining on maintenance therapy, then they're not maintaining. So the first thing I would look at is maybe the frequency needs to be higher. And if you get to a point where your frequency is enough to maintain them, well, that's your frequency. It might be once a week, might be 3 days a week. It really just depends on the patient. The second thing is intensity. And we're talking about Part B here, where you're billing in units. Like, how much care do you need to maintain? Well, if you've been to any of my courses, I talk about the fact that what we're trying to maintain is what's called an underlying impairment. And your underlying impairments cause your functional deficits. So we as therapists, we target the underlying impairment to get to the function. So let's say, we'll just pick a very basic one, range of motion. Now, generally maintaining range of motion is not considered a skill for a long period of time. But let's just assume that it does require our skill. So how many interventions do you need to do that would be an intensity per visit to help them maintain? It might be one intervention. It might be a couple. But whatever the intervention intensity is to maintain them is how much you should be prescribing. Now, one of the things I talk about in my course on documentation is the fact that with a maintenance patient, we really should be trying to find the lowest common denominator of frequency and intensity. So if you are trying to reduce the patient down in terms of frequency and intensity, and you get to the point where the patient starts to decline again, whereas previously you had been maintaining them, you've just discovered the threshold. And so you want to document that very carefully. Now, what about duration? Duration is how long do you keep a maintenance patient on caseload? It's keeping in mind that Medicare's definition of reasonable and necessary care is care that is of such complexity that only you could safely and effectively do it. That's reasonable and necessary care. You have to ask yourself, is everything I'm doing to maintain the patient reasonable, necessary? Is it so complex, like everything I'm doing, so complex that only I could do it safely and effectively? Now, there might be parts of what you're doing that do require your special skills and knowledge to safely and effectively do them. And therefore, if that's needed for maintenance, then you got to keep doing that indefinitely. If you can't possibly train a non-skilled person to do it, you've got to be doing it to maintain them, because that is the patient's right under Medicare, under the Glenda Jimmo provision. That's their right to get that care. But if you look at parts of your care and it's clear that you could train a non-skilled person to do that over time, and they can safely and effectively do it after training, then it's not maintenance therapy. Now, I want to talk about those last couple points for just a minute. Number one, suppose you have a patient who's by themselves in a home setting, like Charles is seeing, and it is possible that if they had a second party in their home, and that second party was willing, able, and available to be trained, and you could train them in that thing you're doing to take that over and then work with the patient, and then that non-skilled person, non-licensed person could maintain the patient, then it's not skilled. Even if they don't have a caregiver there at the home, they're all by themselves. Technically, that would not be skilled. So the patient at home by themselves just needs some range of motion and somebody to coach them through exercises. A personal trainer could do that. It doesn't take your skill, and we shouldn't be billing Medicare for that. So that's one situation. And in that case, what I would be asking myself is, if this patient cannot maintain themselves with non-skilled provision of services, they're in the home, they might not be in the right setting for them. Might not be for them to be in their home setting. So that's one of the big things that I would want to ask myself. The other thing is this: care over time for all patients, whether they're maintenance or not, should be evolving in nature. And you can have a person on caseload for the rest of their life, technically, with maintenance therapy. In fact, Glenda Jimmo, who won the decision against Medicare, has been on maintenance therapy continuously since January of 2013 at least. In fact, I know she was on care before that. And that's been ongoing for 6.5 years at this point. That does not mean that that's going to be the rule, though. In fact, Medicare has a lot of scenarios. Well, not a lot, but they have a few in their policy manual about maintenance care. And most of the scenarios are temporary maintenance, and that's going to be patient dependent. So, for example, in the home health benefit policy manual, Chapter 7, it has 5 scenarios, if I remember right, and 4 of them are temporary maintenance. And I think what Medicare is partly trying to do is be subtle about the fact that we don't expect maintenance to be for the rest of people's life for all people. So you've got to really be careful about proving, the patient needs ongoing care, because at some point, probably, what you're doing is not evolving and changing over time. It does become repetitive, and repetitive care is one of those provisions that Medicare says is not payable. And so at that point, we would say it's not maintenance therapy. That needs to be turned over to what you might call custodial care, a non-licensed person. So anyway, Charles, I hope you found that helpful. It's going to be all patient dependent, regardless of the changes that are coming forward in the future with PDPM, PDGM, etc. Maintenance therapy provisions, the law still applies, and it's all still going to be patient specific. Getting it paid for, that's going to be the big challenge, of course, and we're going to have to really work carefully with our third-party payers, especially the managed care side of things. That's the companies that are managing Medicare's benefits. So anyway, please feel free to subscribe, like, comment below if you have any suggestions or comments, or if you'd like to see other content be discussed, please feel free to message me. Take care, God bless, and have a great day.